Assalamu alaikum. After elevation of the mood and the celebration, I am sorry to start my talk now with the challenges. So I hope you will enjoy it, but it's a very important talk because a lot of challenges is going around regarding hyperglycemia in pregnancy. So it is estimated that hyperglycemia in pregnancy affect around 17% of the population. 83% منهم are gestational diabetes, 10% are due to diabetes prior to pregnancy, and around 10% due to diabetes including type 1 and type 2. Very important for our area to talk about this because recent publication 2022 has been published according to the IDF Atlas, and it has been shown that 30%, according to the analysis done of the population in the MENA region, they have some kind of hyperglycemia in pregnancy, and in Southeast Asia, it's around 25%. So, fluctuation from desired glycemic control may have their effect on the fetal and the material consequences. By early detection and treatment, the outcome of affected pregnancy can improve, and we can reduce adverse event and complication such as hypertension, preterm labor, postpartum hemorrhage, and regarding the baby, we can reduce the incidence of congenital malformation, macrosomia, and metabolic disturbances that occur. Regarding the long-term complication, as you know, every woman who has hyperglycemia in pregnancy or some type of gestational diabetes are prone to have type 2 diabetes, hypertension, and vascular dysfunction, even dyslipidemia, and ischemic heart disease. Within 5 to 8 years, most of the ladies, 50% of the ladies may develop type 2 diabetes. Regarding the offspring of diabetic mother or gestational diabetes mother, they might have obesity, metabolic syndrome, disorder in glucose regulation, high blood pressure, and possible onset of coronary vascular disease. So it is very important to recognize that case and to diagnose and early intervention. There are why we are talking about challenges. كان نقدر نحكي easy to talk about hyperglycemia in pregnancy without talking about challenges, because there is no agreement في hyperglycemia in pregnancy, how to screen, when to screen, and who to screen. ما في agreement. A lot of difference between opinion مع الأطباء. ما في أي consistency إنه when to screen and who to screen. آخر إشي في last 10 years there has been 16 clinical guidelines literature بالإنجليش هدول من Societies International only talking published from 2013 to 2018. That they are inconsistent regarding the timing, the timing of screening, actual which method to screen, to use one-step approach or two-step approach, and the diagnostic criteria for the oral glucose tolerance test. As I said, those guidelines were written in English. So in this lecture, I'm trying to overview the evaluation and the screening method that are used to diagnose gestational diabetes only from the part of hyperglycemia. Issue regarding the timing and the early screening. And very important to remember that we are living in a high-risk area. MENA region counting as a high-risk area, and we have 21 countries inside the region with difference between middle income, high income, and low income countries. If we want to approach for guidelines or consistencies that we agree upon, it has to be very easy and affordable, as well as sensitive and easy to use. So last year we came out with the guidelines that were published in the Journal of Diabetology, the Journal of DASC, And those guidelines contribution was from all the MENA region. So I will depend on some of my talks on the guidelines that were published and starting who to screen. I will defend each sentence, why and who, when. So who to screen? Regarding screening, all of you know that there are two types of screening. Either you do a selective screening or universal screening. Selective screening, or by other word risk-based screening, بيعتمد على الفاميلي history, على ethnicity, previous gestational diabetes, and maternal obesity. Is الأم obese or not? Or other causes of high-risk screening. If we look at the international association, كل الأسوشيشن, the WHO and FIGO and IDF 2012 and the MENA region, our region guidelines, EDAPS criteria, and the Endocrine Society and DIPSI, they recommend early screening at the first trimester. They recommend early screening at the first trimester, and they recommend universal screening for everybody. Now, if we take people who depend on risk-based screening was implanted in ADA, American Diabetic Association, and Canada Association, and many other countries. Let's discuss the NICE guidelines. The NICE guideline, they depend on risk-based screening. So they don't do universal screening. But in their guidelines, which were published last year, they said that we recommend risk-based screening, except for people with high ethnicity risk group. And the people who with high ethnicity risk group, as you have seen, are our people, our population, from the MENA region and from Asia. So if you live in England and you are from Jordan, you have to be screened, whether you have a risk or you don't have because of your ethnicity. So it's obliged to our guidelines. So everybody should be screened in the MENA or Southeast Asia. Another thing, ADA 2023, they published a new recommendation, and you know that the American Diabetic Association, they are with risk-based screening, except the last one, they said, if you have gestational diabetes, you have to be screened for prediabetes. Prediabetes, in the concept of hyperglycemia, in pregnancy does not exist, because if you want to diagnose prediabetes, you have to have blood sugar more than 100 milligram per deciliter. If you want to diagnose gestational, you have to have blood sugar more than 92 milligram per deciliter. Another thing, that if you are high risk, you can have just oral glucose tolerance test before in the first trimester. So let's look at our area. Our area is a high-risk population, Middle East and Southeast Asia. So we have to have universal screening for all pregnant ladies. So we agree that universal screening for all pregnant women in the MENA region, the population is composed of multiple ethnicity, and prevalence of type 2 and obesity and consanguinity is very high. The best strategy is to do universal screening لكل وحدة حامل. Now, إمتى نسوي universal screening? Risk-based screening was studied in multiple studies, and they compare between the universal screening and risk-based screening, and most of the studies found that if you do risk-based screening and redo universal screening, that you will miss a lot of cases. And one of the study was done in Pakistan, showed that 25% of women were diagnosed with GDM had no risk factor at all. In Malaysia, 24% of women with GDM didn't have any risk factor to be selected for screening. So when to screen. You know that early pregnancy, there is a concept called early gestational diabetes. Early gestational diabetes is to develop gestational diabetes, hyperglycemia before 24 weeks of pregnancy, but you are not fulfilling the criteria of the pre-existing diabetes. In the opinion of WHO, anytime you are diagnosed with gestational diabetes, whether it is the first, the second, or the third trimester. And the programming that occurs in the first trimester is very important, because the first trimester is the stimulus. If there's any hyperglycemia and stressful stimulus, it is very sensitive period for the development of the embryo and the mapping of the child, of the fetus. Now, if we go to the guidelines, WHO, FIGO, they all go with first trimester screening. So in our guidelines, we recommended first trimester screening, and the aim of the screening to detect undiagnosed gestational or to detect any lady with hyperglycemia in pregnancy, and to focus on early GDM. So it is justified. Second trimester الكل موافق عليه. Everybody does second trimester screening. So there is no controversy بهذا الحكي. And the third trimester recommended if the first trimester or the second was negative and there was ultrasound finding hypermesis, so you do third trimester screening. How to do screening? بدي استعجل. زي ما بتعرفوا, as you know all, we have one-step approach or two-step approach. One-step approach, when you give 75 gram oral glucose tolerance test and you do blood sugar at 0, 1 hour and 2 hours. And the two-step approach, when you give 50 gram anhydrous glucose, non-fasting status, and you ask the lady if it is positive to come again, and you give her 100 gram and you do 3 ساعات, 3 hours of testing. You require, when you do two-step approach, 2 abnormal values. So what are the advantage of one step and disadvantage? The disadvantage of the two-step, that it has a higher missed cases, it is difficult to follow up, and so it delays the treatment. For example, if a woman lives in Jordan in a rural area, and I gave her 50 gram anhydrous glucose and it was positive, I should ask her to come again and do the test for 100 gram. It is very difficult, very expensive for her to come again. So it is not applicable in our area. Let's think about the the one-step approach. It is easy, very easy to implant, and you have to have one abnormal value, which is, you start with 92 milligram, 1 hour 180, 2 hours 153. Advantage, very simple to follow, easy to diagnose, and more identifying gestational diabetes. Disadvantage, the lady has to come in a fasting state. So it is recommended, and there is an alternative approach. If the lady doesn't come in the fasting state, you can use DIPSI method, Diabetes Asia Study Group. You give 75 gram in non-fasting state, and Dr. Lubna applied this method in Egypt, and it was really good. The other method, if the woman cannot take anhydrous glucose, you can take just fasting blood sugar. And I will emphasize one point, that depending on fasting blood sugar is very good. The sensitivity and specificity of 92 milligram per deciliter can approach 100%. But if you don't have anything except fasting, do fasting blood sugar. Hemoglobin A1C is not recommended at all for screening of hyperglycemia in pregnancy. It can be used as follow-up for pre-existing diabetes, and it can be used just to evaluate the risk factor of pregnancy. If you don't have lab, just do glucose check. In summary, because I want simple and clear guidelines, I always recommended at first prenatal visit, it's very good to do the test. Use 75 gram anhydrous glucose or depend on fasting. Just examine the lady. She missed the first trimester or second trimester. And that always ensure that the guidelines should be applied all over. And remember, sailing in a rocky sea damaged the boat. Please take care of our pregnant ladies, and thank you.